We've heard a lot about workforce challenges and policy solutions today, and we wanted to close with an example of how an innovative collaboration in Minnesota between providers, a health plan, and community partners is helping to connect women to prenatal care. And I'm pleased to now introduce Ashlyn Christianson, Public Health Manager of Government Market Solutions for Blue Cross Blue Shield of Minnesota.
Hello, and thank you for your interest in learning more about our high-risk pregnancy pilot. My name is Ashlyn Christianson, and I currently manage the day-to-day of the pilot. What prompted Blue Cross to become interested in a maternity care pilot? As a payer, Blue Cross historically has not had the feet-on-the-street expertise that other local agencies have. We rely on the data that comes from claims to understand the health of our insured population. And as you're probably aware, sometimes claims are not coded correctly. Claims are sometimes submitted months after the appointment occurred, and not everyone who is insured gets preventative care or seeks out medical care to control a medical condition. Additionally, limited information that we glean from claims data causes us to fill in the blanks. It does not provide us with understanding the whole person, and it leaves us at a disadvantage to understanding true population health. Our current maternity management program is a telephonic opt-in program. Women who are pregnant can call in to speak with a case manager who can give them information about a healthy pregnancy. We are limited with this telephonic program because the case managers do not leave the building. They do not have the community relationships to refer pregnant women throughout the state, nor may they understand the external barriers that the pregnant women may have when trying to access care, such as available transportation in that community. We decided to be bold, and we decided to innovate. The idea for this pilot came from external Blue Cross relationships and the understanding that we have to meet the members where they are. After traveling to about 4/5 of the counties in Minnesota and speaking with public health agencies, I heard that public health overwhelmingly identifies pregnant women as early as 8 weeks into pregnancy through WIC clinic referrals. At Blue Cross, we are lucky to find out if a member is pregnant between their 4th and 7th month, if the provider bills us in a timely manner, and if the member gets any prenatal care at all. So I went to Ramsey County Public Health, which is St. Paul, Minnesota, our largest membership population at the time, and I asked how the referral process went for them. At that time, half of the pregnant women in WIC accepted a referral to public health, but only half of those referred actually followed up with public health. So Blue Cross wanted to help individuals make connections with the agencies who could assist them with better birth outcomes. We knew that Ramsey County has the best evidence-based home visiting program in the state, and we wanted to partner with them to increase referrals and to get better pregnancy outcomes for our members. To do so, with public health and WIC's blessing, we wanted to support the hire of a community health worker, or CHW, place the community health worker within the 7 WIC clinics in Ramsey County, and have the community health worker identify pregnant women on the spot to immediately engage with them and to have warm handoffs between agencies and community support systems. Our hope was that once the position of the community health worker was established, it would become reimbursable through claims, sustainable, and replicable across all counties in Minnesota. Here is the example of what we set the community health worker up to do. The role of the community health worker is to be able to assess needs, connect mothers and their families with needed resources, refer and provide warm handoffs to other community agencies, and provide education as appropriate to the mothers about their pregnancy. Because we're a little short on time, I won't go into too much detail on this graphic, but it does show the journey and how the community health worker is able to insert herself throughout. In this example, the woman's name is Nicole, how the community health worker can insert herself into Nicole's pregnancy journey and assist with any needs that Nicole may have or any barriers that she has that takes her away from focusing on her pregnancy. Here's a model that shows how the community health worker is in the center of care. First, finding the individual at a WIC clinic, but then following up with the individual at the location of their choice. The community health worker also does warm handoffs and referrals to community organizations, and depending on the risk assessment, refers the individual to public health, to the telephonic maternity management services, or to other community programs. Some lessons learned so far. We are about 4 months into the pilot, and let me tell you, we have learned so many things. With the community health worker, we insisted that the community health worker not be a Blue Cross employee. We gave startup funding for this pilot to a provider agency called Livio. Livio is a mobile clinic that goes to where the people are to provide services. The CHW is now an employee of Livio and has access and connections to physicians, social workers, and a nurse midwife. Community health workers are an emerging profession. Many are inexperienced, or their experience that they do have is very limited in scope. The community health worker program is approximately 14 credits. It takes a minimum of 120 days for the Department of Human Services here in Minnesota to credential a community health worker. So during the waiting period, the community health worker is unable to get reimbursed. So upfront funding support is needed for any new community health worker graduate. Additionally, one of the lessons learned for the community health worker is that it has taken an incredible amount of resource-intensive oversight. When it comes to care planning, reimbursable hours, training, professional development, motivational interviewing, ethics and barriers, computer programs. So for example, the community health worker that we initially hired was fresh out of school, had no healthcare background, and wasn't sure how to use an Excel form, a document. So we had to do a lot of education and training to make sure that documentation was accurate and that we could use that data later on. Some of the lessons that we learned partnering with WIC. Because there are 7 WIC clinics in Ramsey County, there's not enough traffic at this time to justify 7 individual community health workers. We're starting with 1 community health worker and placed her on a rotation at the most high-traffic WIC clinics. We put iPad kiosks at the other locations with simple intake questions that asked about social determinants of health. We found that when calling or texting the moms for follow-up, they were more likely to engage with the community health worker if the community health worker had a resource or solution for their housing, food, or other needs. I have to say that WIC has been a fantastic partner. They're allowing an outside agency to take up space in their very small clinics, and they have been willing to use their very limited staff to inform pregnant women of the pilot and the opportunity to connect with a community health worker. The Wi-Fi in the WIC clinics is unreliable for our iPad kiosks to work consistently, so that has been a barrier to downloading and collecting information that the women input in the kiosks. Probably the most major takeaway is the WIC staff buy-in is the most important, because they need to trust this new community health worker who's invading their space so that they're confident in referring the pregnant women to either the community health worker or the iPad. So we've been sharing our success stories with WIC, and that seems to motivate them, knowing that women are being taken care of. WIC does not care about insurance coverage for their individual women. Their focus is on nutrition education, and they believe that if someone is willing to jump through hoops to get to WIC, they need the assistance and will provide the education. Insurance coverage has nothing to do with WIC services, so WIC is considered a safe place for individuals because WIC does not ask intrusive or prodding questions. Women feel comfortable going to WIC and they spread the word. I think that's why WIC has been such a high traffic area for this population. Our lessons learned with public health. At Public Health's request, we have decided to open up training for all public health staff and WIC clinic staff to attend IDI trainings, which stands for Intercultural Development Inventory. It is important for Blue Cross that our partners have cultural competency awareness training as they meet with our members, and as the demographics of Ramsey County and the state of Minnesota have significantly changed, we believe that having this cultural competency will lead to better engagement and better health outcomes for mom and baby. Livio, the mobile clinic. Livio is a startup. so getting the kinks worked out of a brand new provider can also be a challenge within a pilot. Technology setup took more time than anticipated, and language translation for our kiosks was a little delayed. Lessons learned, and Livio needs the ability to text clients. Mail and phone calls are not generally successful when reaching out to individuals, but text messages offer more success. Pregnant women. Most, about 50 to 70% of the women who are going into WIC have no insurance coverage. So the claims numbers we based our pilot metrics on show that the bulk of our membership begins when a woman delivers and not before, meaning that without women who are consistently covered by insurance throughout the 9 months prior to delivery, there's no way for Blue Cross to find or assist these moms in getting appropriate prenatal care. For these women who show up at the WIC clinics and do not have insurance, the community health worker refers them to an agency called Portico HealthNet. Portico HealthNet has certified MNsure navigators, which can assist the individual at no cost in choosing a health plan that works best for her. Additionally, most Medicaid members don't know who they have insurance through. They know that they have insurance, but they are unsure of who the coverage is with. Many do not actively select a health plan, and the health plan is chosen for them as the default in each county. This means that many of the women that the community health worker is interacting with do not even know what benefits Blue Cross offers them, even after all of the informational mail we send out to the members as required by the state, or the mailings that we send out as education for the members. There's a low level of literacy. One woman that met with the community health worker did not know that she was getting a McKenna shot to reduce her chance of a subsequent preterm baby. She just knew that she was getting a weekly shot from her doctor. Finally, trust. Pregnant women often ask the community health worker if she is a social worker. This leads us to believe that they have not had great experiences in the past with social workers and are willing to work with the community health worker because she is not one. Some potential barriers that I have noticed while working on this pilot. Churn impacts the continuity of care. If a member has Blue Plus in May, but falls off eligibility in June, and then chooses or defaults to another health plan for insurance coverage in July, there are so many potential impacts to the outcome of that individual's health. Perhaps the doctor that is in the Blue Cross network is not in the competitor's network, or the individual who goes without insurance is unable to seek prenatal care, or the provider who is seeing the individual is not able to bill for a global payment package because the individual did not have consistent health plan coverage for all of the prenatal visits. Which leads us to the DHS rules. DHS forbids health plans from reminding members by text message that their coverage is about to lapse. This creates gaps in care and can create higher costs for everyone. Additionally, health plans have been explicitly told that we are not to collaborate with the counties to get pregnant members into the appropriate risk rate cell for pregnancy. Instead, the Department of Human Services wants the health plan to inform our DHS contract manager of the pregnant woman. Then DHS will tell their operations department. Then the operations at DHS will mail out a letter to the individual asking the individual to contact their financial worker. I think you understand the complexity and delay in coverage this causes for the individual. If any of you have worked with the Medicaid population or any population that receives mail for that matter, you understand that most of the paper mail sent out goes straight into the trash. Medicaid members also include a population of mobile and homeless individuals who may not have a current mailing address on file. When a member is in the appropriate rate cell, the door opens for the member to have zero copays, and they are given additional prenatal benefits. This is a huge loss for pregnant women who may not be able to afford expensive prenatal vitamins if they are not in the correct rate cell, and those women who go to the emergency room for care instead of seeing a regular and consistent provider. This is also a huge loss for health plans and the public because without appropriate access to care or access to medications and vitamins, healthcare costs can go up for everyone. On to clinic policies. Many clinics have a policy not to see a pregnant woman until 9 weeks, and even then the pregnant woman doesn't get to see her healthcare provider. At 9 weeks, the clinic just does an intake. It is at 12 weeks that they are able to see their provider. For this pilot, if the community health worker identifies a pregnant woman before 12 weeks, we found that it was best for the community health worker to refer to an FQHC, which are federally qualified health centers. FQHCs have an open-door policy. There's no minimum pregnancy requirements to see pregnant women, and they always keep last-minute appointment times on their schedules to get individuals in the same day, which is a huge win when working with an engaged member who is willing to get prenatal care set up that same day. Additionally, one of the Ramsey County WIC clinic locations is in the same building as La Clinica, one of the FQHCs, so warm handoffs are especially smooth at this location. Already into the pilot, we have stories of success. Capacity building between participating agencies. WIC can now focus on nutrition education. The community health worker focuses on all of the other social determinants and pregnancy education. Livio now has more clients and increased staffing capacity. They've added some community health workers to work on tackling other issues for members. Public health has increased referrals into their evidence-based home visiting programs, Nurse Family Partnership, Healthy Families America, et cetera. Blue Cross, we now have healthier, happier members. We're looking forward to lower costs of low birth weight babies, preemies, and NICU. Additionally, individuals' needs and social determinants of health are being met. One of our success stories is of a family who met with a community health worker and learned that Blue Cross offers free transportation to medical appointments. The husband began to cry as they only had one vehicle in the family, and he was caught between taking his pregnant wife to medical appointments or going to work. Now his wife would have access to transportation through Blue Cross, and he could keep his job. Members also report providers do not have time to answer questions and concerns while they're in their office. So the community health worker is a huge help for the individual in clarifying what occurred during an appointment and to get the individual's questions answered. One more success story. A woman had sickle cell and did not get along with her financial worker, so no one at the county was aware. She disclosed her medical condition to the community health worker after a couple of interactions and was able to get additional support and education about her condition. I have a list here of some thoughts about expanding to the rest of Minnesota, but the main takeaway is that one size does not fit all for every county in Minnesota. There are so many nuances. I know this was brief and a high-level overview, but I hope that it was enough for you to get thinking about bold and innovative pilots and programs also. Please feel free to contact me if you think of any questions after this webinar.